Hello guys, today Keshav Gupta. I'm MS ENT from ERA's Lucknow Medical College. Today I would like to discuss with you about the vestibular function test. Before starting my topic, I would like to thank my Gurudev Shri Guru Ashutosh Maharaj Ji for all his grace and for giving me this idea of starting this new venture of online videos for our PG students. So today I will be discussing with you about vestibular function test. Vestibular function test, these can be divided into two types: clinical function test and laboratory function test. In clinical function test, we are having a variety of tests. Clinical function tests are the tests that we can do on patients in OPD basis only. It includes tests like gait test, nystagmus, Dick-Solvite maneuver, cerebellar function test, Romberg's test, Sharp-and-Romberg test, and we will discuss all these tests one by one. Starting with the nystagmus. What is nystagmus? Nystagmus is rotatory movement of your eyes. It is to and fro oscillatory movement of your eyes. We decide direction of nystagmus according to the fast component of the nystagmus, according to the fast component of the oscillatory movement of your eyes. So, actually, nystagmus has two components, fast component and slow component. So we decide the direction of nystagmus according to the fast component of the nystagmus. And broadly, we divide nystagmus into two types. It can be peripheral or it can be central. In peripheral nystagmus, it is due to normally vestibulocochlear nerve, and central nystagmus involves our brainstem, our midbrain, and so on. So we will discuss here different conditions where there is different direction of nystagmus. Let's start with the labyrinthitis. For example, in serous labyrinthitis, we are having nystagmus towards the healthy side, and in paralytic nystagmus, paralytic labyrinthitis, we are having nystagmus towards the healthy side. So, and one thing more, we can even divide nystagmus into three more types. That is horizontal nystagmus, vertical nystagmus, and torsional nystagmus. Normally, vertical nystagmus and torsional nystagmus is present in cases of central lesion. Central lesion here means involving midbrain, brainstem, and so on. And there are some more characteristics that divide these peripheral and central nystagmus. When we talk about peripheral nystagmus, the nystagmus that is peripheral in origin is normally fatigable. It has latency. And that nystagmus, fatigable here means that nystagmus wears off with time. But in central nystagmus, it doesn't wear off with time, and it is non-fatigable. So it is non-fatigable, and this is all I wanted to do to talk about nystagmus. Now we will go on to our next test, that is gait test. You all must have heard about the gait test. Gait test we generally do on patients with closed eyes, and we tell the person to walk in a straight line with closed eyes. Suppose you can see me here. I am standing in front of you, and I'm seeing in front. Then I will close my eyes and I will walk in straight line with my eyes closed. I am trying to walk in straight line. So this is normal gait test. But in patients who are having abnormal gait test, we will see that the patient will sway, patient will move towards the side of the lesion. Suppose patient is having lesion toward his right side, the patient will be moving towards the right side. Let's see it. Standing in front of you with my eyes closed, I am trying to walk in straight line. But due to lesion, there will be change in direction towards the side of lesion. So, this is all I wanted to tell you about gait test. Now, we will discuss about something more, what we call fistula test. Fistula test, fistula test we are talking about here is basically change in pressure of your external ear. It can be with use of cecal speculum or pressure on trachea, like you can see here. With the change in pressure in external auditory canal, we see nystagmus in the patient. In normal person, fistula test is negative. That means in a person with negative fistula test, with change in pressure in external auditory canal, there is no nystagmus observed. But in patients with where we change pressure, where we press the tragus or we use cecal speculum and change the pressure of external auditory canal, we observe nystagmus. And that nystagmus can be due to many reasons. Normally, truly positive fistula test is observed in patients who have undergone fenestration surgery, who are having abnormal horizontal window or oval window, or the patients who are suffering from canal dehiscence, semicircular canal dehiscence. They will show positive fistula test. And even there are false positive fistula tests that we can see in patients like patients of Meniere's disease and patients of syphilis. So someone can ask you why we see positive test in patients of Meniere's disease and in patients of syphilis. So let me tell you, this is due to the hypermobile stapes that we are having the false positive fistula test. And one thing more, you must have heard something like false negative fistula test. Here, false negative means the patient should be having positive fistula test, but the patient shows false negative fistula test. So, can you think of any condition where patient should be having a positive fistula test, but he is showing false negative fistula test? Let's think about it. So, we discussed earlier that we see positive fistula test in patients of horizontal canal dehiscence or semicircular canal dehiscence. So suppose we close that dehiscent part with cholesteatoma, then the patient who should be having a positive fistula test will show false negative fistula test. I hope you have got it all. So next thing we will talk about is Romberg's test. I hope you all are familiar with the Romberg's test. We generally do Romberg's test as a clinical test. So let me show you how we do Romberg's test. In Romberg's test, patient should keep his or her feet close to each other with arms by the side like this, and with patient is standing and with eyes closed, and we see for any change or any movement of the patient. In patient with peripheral lesions, patient will sway to the side of the lesion, and in central lesion, patient will be unstable. And there is one more test that we call modified Romberg's test. So, modified Romberg test, when we discussed about modified or sharpened Romberg's test, it is a modification of the normally done Romberg's test. In this test, our arms are folded like this, and our feet are such that our heel of one foot touches the toe of other foot, and we stand with the eyes closed. So sometimes we can have a negative Romberg's test, but positive sharpened Romberg's test. And as we see in Romberg's test, we see in sharpened Romberg's test, the person will sway to the side of the lesion in peripheral lesions, and person will be unstable in lesions of central origin. So this was all about fistula test, Romberg's test, nystagmus, and gait test. So next thing we will discuss is about cerebellar functions test. You must have heard about cerebellum. Cerebellum, yes, cerebellum. Cerebellum is part of brain that help us in movements, in synergistic movements. So, sometimes cerebellum is the cause of vertigo, or we can say imbalance in people. To test for the cerebellum, we are having some test that we can easily do in OPDs. Like there is asynergia, like there is adiadochokinesia. That is, person can't do alternate fast movements. Like you can see my hands, like this. Supine, prone, supine, prone, supine. Person can't do these alternate movements quickly. There is rebound phenomena in patients of cerebellar dysfunction, and the range of movement is affected. That is asynergia. So this is about cerebellar functions, and patient is having abnormal gait, and in patients of cerebellar dysfunctions. And one thing more, yes, I would also. I forgot to tell you about Dixon-Pike test. Dixon-Pike test is another test. In short, we say it as DHP. DHP is a test to check the functions of semicircular canals. It's a test to check for the vertigo, of differentiate the vertigo from the peripheral or central cause. Let us now discuss how Dixon-Pike test is done, how it should be done. When we do Dixon-Pike test, we make the patient sit over a couch, or it's better to make the patient sit over a table such that in a supine position. Patient sits. First, patient lies in supine position. Then we can make the patient sit for a while. While patient is sitting, we turn the head of the patient 45 degree, and suddenly we take the patient make the patient supine such that the patient's head is stable in our hands in 45 degree, and it is 30 degree below the horizontal of the table. And now we observe for the nystagmus. We observe for the latency of nystagmus, the direction of nystagmus, and the fatigability of the nystagmus. As I have discussed earlier, the nystagmus that is of peripheral origin may or will show latency. It will show fatigability. And the nystagmus that is of central origin will be, can you guess what should be nystagmus of central origin? Yes. Peripheral of the nystagmus of central origin will be non-fatigable. It won't show latency. That's how we differentiate between central and peripheral nystagmus. And yes, one thing more I would like to tell you, other tests we perform are the laboratory tests. Laboratory tests are the tests that we can't perform on patients in our OPD. So we need special arrangement. We need special arrangement to perform those tests. So I would like to tell you about some names of a laboratory test like caloric test, optokinetic test, galvanic test. So these are some of the rotatory tests or laboratory tests that we perform in patients. So thank you so much, and thank you so much for listening to me, and hope you will give support, and it will be a helpful video for my juniors and for my juniors, and it will help in you can say furnishing your knowledge about ENT. So thank you guys, thank you so much, and I hope you will like my video. Thank you guys. See you again.